All right, guys, Dr. Nate here with Made to Move PT. We are going to talk about a condition called frozen shoulder. So this used to be called adhesive capsulitis, was a very popular term, and a lot of people still use that term. I want to go through a little bit of the history of frozen shoulder and basically how we came to be able to diagnose it, what it is, what is going on in the shoulder when it happens, and basically how it's treated and maybe how we can treat it better. So historically speaking, the first time it was called frozen shoulder was by a physician named Dr. Codman, and he was a pretty bright physician. He did a lot of really important things. We still have some exercises named after him, and he wrote a book called The Shoulder, and then there's there's a subtitle under that. But in it, he described a condition called frozen shoulder, in which it didn't look like anything was actually going wrong with the shoulder itself. So there were no injuries to it, nobody had fallen, but it just started to become very, very painful and lose range of motion. And so typically what will happen in frozen shoulder is that we see this movement first, this abduction up to the side starts to go away, and external rotation starts to decrease. So those two ranges of motion right there start to decrease, and particularly external rotation at the side right here. So he described this, he said this is not an exact quote, but this is a very confusing condition. Don't really know why this is happening, but I know that other things are not happening, so I'm going to call this frozen shoulder. So it was called frozen shoulder until I think it was 45 or something like that. So about a decade later, a physician named Navassier, I don't know how to say his name, decided that he was going to call this condition adhesive capsulitis. So he had been doing shoulder surgeries on people where he would basically cut the anterior capsule of the shoulder joints. So you have this connective tissue around your shoulder that helps to hold it in place. And the anterior capsule, the forward part of the capsule that holds your shoulder, he was releasing it, and people were regaining a significant amount of shoulder range of motion after he did that. And so he decided, okay, it was called frozen shoulder, but now I think there's an adhesion in the front part of the capsule, and so I'm going to call this adhesive capsulitis. And that's kind of what we ran with for the last 70 or 80 years, is this idea of adhesive capsulitis, up until recently, actually. So surprisingly enough, so we've known about this as a condition since 1935, 34, whatever. We've actually known about this earlier. Other physicians have described it. They just didn't call it frozen shoulder. So it's been around for a few hundred years that we've known it's existed, and we still don't really know what causes it. So there is probably this complex multifactorial kind of thing that happens, and we'll talk about that here in a second. But basically, the way this has historically been treated, so after it was called adhesive capsulitis, clinicians kind of got in their head like, okay, the capsule is adhesed down, it's become fibrotic, we need to really stretch the capsule to get there. And the problem with stretching the capsule is that it's very, very painful. The shoulder is painful. There have been biopsies done where they take pieces of the connective tissue out of people that have frozen shoulder, they look at the joint capsule, they do MRIs, all this kind of stuff. And what they basically found is that the capsule does become a little bit fibrotic. In other words, there's scar tissue that's being built up. So there are a bunch of immune cells that come in. There are inflammatory cytokines, these molecules that help to create an inflammatory response. There is actual new growth of blood vessels and new growth of nerve tissue inside of the capsule. And basically the capsule just looks really, really, really angry. So the joint capsule, something is happening to the joint capsule where it gets very angry. And then what happens is when the joint capsule has a large inflammatory response going on, all these immune cells, all this stuff, your brain becomes very sensitive to what's happening in that joint capsule. So all of the nerve endings that are there start sending more and more signals to your brain. They start to become activated by this inflammatory response, saying like, hey, something is happening here, there's been a chemical change. Your brain interprets that as a threat, and it starts to create a very high level of pain so that you don't move the shoulder. It believes there's a very big threat to the shoulder. And so what will happen over time is the joint capsule will actually start to lose a little bit of volume, and we'll talk about why this may not actually be the joint capsule shrinking here in a second. But the joint capsule will go from being able to hold maybe like 20 milliliters of fluid, I don't know, I think it's 20 milliliters of fluid, down to about 5 milliliters of fluid in some people. So it actually loses volume, and it's particularly this anterior capsule that starts to become very, very, very tight. And so historically we've said like, all right, we need to stretch on that, we need to do surgery to release it, we need to do things like that. And sometimes it works, sometimes it doesn't. So some of the surgeries actually do work kind of okay. If someone has frozen shoulder and it doesn't seem to get better on its own, or with conservative care, then we can do a technique called manipulation under anesthesia, where you knock someone unconscious, you just crank their shoulder into the end range of motion, it tears the anterior capsule, tears other connective tissue. In some cases it tears the rotator cuff and the labrum and other things that we don't want to tear. but people do regain range of motion from this, usually fairly well. So other ways of treating this besides the manipulation under anesthesia is we've tried conservative care, basically physical therapy a lot. We've also tried cortisone injections, so trying to decrease that inflammatory response inside the shoulder, and that does seem like it has a decent effect. So with physical therapy, the idea has been for a long time, and I've said it a few times, is to crank on the shoulder, really like try and stretch that anterior capsule, stretch the joint capsule back out. The problem is that when there's that significant threat response, when your brain is deciding, okay, there's a big threat in the area, if you try and stretch someone into that and they start to get a high level of pain, you're not stretching the joint capsule. You're moving the joint capsule. Your brain is already sensitive to what's going on due to that chemical change, and then your brain starts to become very sensitive to mechanical change too. So even just a tiny little bit of stretch that can't create structural change, your brain is going to say like, hey, don't do this. This is a threat. And so what happens from there is your brain also creates the response of making your muscles super, super tight. So your brain is not going to let you move into a range of motion that it deems to be threatening, so it's going to make all the muscles in your shoulder clamp down really, really hard. So this looks like your subscapularis, infraspinatus, teres minor, supraspinatus, basically all the muscles of your rotator cuff, your pec, your delt, your lat, all get super tight, and your brain won't allow you to actually put a stretch on the joint capsule by using those muscles to prevent that from happening. And so when someone is cranking on someone's shoulder, on a patient's shoulder, and a physical therapist is like, all right, this is a frozen shoulder, it's going to hurt, I'm sorry, it's going to be worse than pregnancy, it's going to be worse than giving birth, we're just going to crank on it, all they're doing is arm wrestling with the patient. And they're not going to win that, because when the brain decides the muscles are going to crank down and be tight, you're not going to be able to break that. So basically they're arm wrestling with the patient and creating a very high level of pain, and all that does is feed into the threat response, and that just makes it worse over time. We have actual research looking at this. If you push people through that high level of threat and into that high level of pain, they're going to suffer from frozen shoulder for longer. And so we have to treat this through the lens of pain science, where we basically accept like, okay, a lot of this is muscle guarding, and there's actually a really cool study, it's a case series, and it was just 5 patients unfortunately, and it just came out a couple of years ago, looking at this idea of muscle guarding and does it contribute to frozen shoulder. So they took these 5 people who were going to undergo manipulation under anesthesia anyway, and they measured their range of motion while they were conscious, and then they measured the range of motion after they were under anesthesia, but before the manipulation. So they basically like looked at the range of motion while their brain was telling the muscles to be tight and while their brain was not telling the muscles anything. And what they found was between 55 to 110 degrees of range of motion returned when you take the brain out of it. When there's no threat response and the muscles just relax, these people gained almost full range of motion. I think 4 of the 5 basically regained full range of motion while they were unconscious. One of them was still a little bit tight, and maybe her capsule was actually a little bit decreased in size. And so what the authors posit here is that the rotator cuff has attachments onto the joint capsule. So subscapularis in particular, when it contracts, it pulls really hard on that anterior joint capsule. And it might be that when the rotator cuff is contracted up, when your brain is telling it to contract up, it does decrease the functional size of the joint capsule. But when the muscles relax, maybe that joint capsule has enough room to move again. And so there's a good chance, and this is just based on 5 people again, so we probably need more research in the area, but there's a good chance that most people with frozen shoulder don't have this adhesive capsulitis thing going on. They have muscle guarding, and unless it's a very advanced or they've had it for a really long time, that capsule is probably not what's limiting their range of motion, and so we don't need to try and crank on it. And you can't crank on it anyway because of the muscle guarding. So what we need to do is address the threat response by the brain. So if the brain is saying contract those muscles up, we need to convince the brain there's less of a threat. So part of this is that there is that inflammatory response in the shoulder. There's a lot going on in there. And so that's why sometimes a cortisone shot might help, dietary changes. There's a significant correlation between frozen shoulder and a lot of autoimmune disorders. So diabetics are around 6 to 8 times more likely to have a frozen shoulder than non-diabetics. Hashimoto's thyroiditis, multiple other autoimmune disorders are associated, other systemic diseases too, such as Parkinson's disease, are associated with frozen shoulder more than the general population. And so other things can come into play with this too. If you think about other things that sensitize your brain to threat, just like life stress. A lot of the patients I see that come in with frozen shoulder have recently experienced significant stress in their lives. I had one lady who her shoulder was cranked down, and it happened in like 2 weeks. She was coming in, it looked a little bit like maybe rotator cuff tendinopathy, and she was fine, like it was getting a little bit better month to month, and then all of a sudden within 2 weeks she had some significant life issues happen, and her shoulder just froze on down. And it was well over a year before she even started getting close to normal range of motion with that. And so sometimes just the life stress contributing to what's going on can cause your brain to go into that threat response mode. So what it looks like with frozen shoulder is that even though we still don't technically really know what causes it, there are probably things that contribute to it. So there may be something going on in the shoulder joint. A lot of people come in and it looks like maybe they had some rotator cuff tendinopathy, maybe like some bicep tendinopathy, maybe a little bit of labral irritation, nothing big that you would think would actually cause an issue. But that, and then combined with life stress, and then possibly some sort of autoimmune disorder or something like that. And then a lot of the time what we'll see with these patients too is this significant neural tension, so sensitivity to stretch on the nerves going down the arm. And so what that what that can say is maybe there's something irritating the nerves anywhere from the neck down to the fingertips. The nerves down the arm are more sensitive to stress going through them now. And the way we actually stress those nerves, the way we put tension on many of the nerves going down the arm is when we externally rotate and when we abduct. They kind of run under the humeral head here. And so that creates tension on those nerves. And those are the two ranges of motion we see decrease the most quickly with most cases of frozen shoulder. And so we have that nerve tensions, life stress, possible autoimmune stuff, possible slight insult to the shoulder, all these things come together and create this like overwhelming threat response by the brain that tells the shoulder, the muscles of the shoulder to crank down and to not let the shoulder move, creates a very high level of pain so that you don't want to do things. And then over time that capsule might become, and it probably takes a really long time, but that capsule might become a little bit tighter too, or it just becomes tighter because the rotator cuff is pulling on it. So how do we treat this? Exercise is probably one of the best ways. So what I've kind of found is a lot of the time you can trick someone's brain into being okay with things if you put a little bit of weight in their hand. So if someone isn't able to pick their arm up to the front, like they get here and it's like, oh, that really, really hurts, I can't do it anymore. If you lay them down on an incline bench press and you put 10 pounds in their hand and have them bench, a lot of the time they'll actually have more range of motion up to the front than they would with just trying to pick their own arm up. And it's not because like anything's weak or anything like that, although things do become weak when you don't train them. It's because you're putting a different stimulus through the arm. The brain is paying attention to the weight in the hand and paying less attention to the shoulder, and all of a sudden the muscles are working a little bit better. And this works pretty well with people who have a history of, like kind of doing these movements of strength training, because the brain falls into those movement patterns and deems them non-threatening versus just trying to pick up the arm. So other things are we do want to keep the rotator cuff strong. The stronger you get the rotator cuff, the less reason your brain has to think the rotator cuff is threatened by anything, and it starts to be able to increase the range of motion. And then gentle stretches. So you want to move your arm into these ranges of motion, but you don't want to make it like an 8 to 9 out of 10 pain. And so like using assistance, so using a band to help you get your arm up to the front, to the side, rotate out, any of that kind of stuff can be really helpful. So a little bit of stretching, but not cranking, because then all you're doing is arm wrestling with the muscles of the shoulder. So that is my rambling on frozen shoulder. If anybody has any questions, feel free to reach out.